This is Erythrocyte disease part 2 tutorial presented by SchrDbb with reference Color Atlas of Hematology by Harald Thelm. So we are going to continue with what we have seen in erythrocyte diseases. So we continue with normochromic anemia, normochromic renal anemia. Now this is another form of anemia, a normochromic anemia, which is due to renal disorder. Now at times this anemia may be hypochromic or may be hyperchromic, but usually maybe it's due to its normochromic. Why? Because when the kidney normally produces the hormone called erythropoietin, and when there is a kidney disorder like in chronic renal failure, the kidney do not produce again those like in chronic renal failure, the kidney does not produce again those erythropoietin. Since it does not produce the erythropoietin, there is not going to be red blood cell production. There is not going to be stimulation for red blood cell production that is going to cause a normochromic anemia. Now the question they are going to ask me is why is that it is normochromic anemia? It is normochromic anemia because it is the kidney that is not producing the iron. Is it clear? The iron is in the body. The iron which is required for the normal red blood cell to be produced is present in the body. Is it clear? So since it's present in the body, it's not going to be hypochromic. Is it clear? So there's not going to be enough red blood cell just because there is low level of erythropoietin and not because there is low level of iron. Because iron is the hallmark to show you that there's going to be a hypochromic anemia. Is it clear? And now when you have excess iron, it's going to be a hallmark to show you that there is a hyperchromic anemia. So we have seen that, so we say normochromic anemia should always suggest the possibility of a renal insufficiency, which will always lead to anemia within a few weeks. Is it clear? So apart from poikilocytosis, the red blood cells are morphologically unremarkable. So that is one, you can have a poikilocytosis and you can have red blood cell unremarkable. Is it clear? And the reticulocyte is often remain normal. So you see, you have an anemia and you don't have an increased number of reticulocytes. So it make you think that there is nothing like hemolysis that is occurring in the body. In this case, it's because of low level of erythropoietin. So the bone marrow does not show any significant characteristic changes, and therefore severe diagnostic purposes in this situation should diagnose the renal failure, because there is no problem with hemolysis, that is, there is no change in the reticulocyte number. Is it clear? That's the first thing. There is no problem with the production level, that is at the level of the bone marrow. So there is no problem there. So it means that the problem is coming elsewhere. So you have to think of renal insufficiency. Now the next one, you have anemia due to renal insufficiency are usually normochromic, but in cases it can be hypochromic or hyperchromic forms so do occur. Hypochromic anemia is an indicator of reactive process that has led to renal insufficiency. Is it clear? So like if you have a renal insufficiency from a pyelonephritis or a glomerulonephritis, in this case you see that what the pyelonephritis was initially an infection. Is it clear? So in infections, you are going to store your iron in the body. So when you store iron, you are going to have low level of iron in blood. So you are going to have a hypochromic anemia. So provided that the renal failure is due to a pyelonephritis, you are going to have a hypochromic anemia. Is it clear? So that's going to cause me now a secondary hypochromic anemia. Is it clear? That's the case. Now in addition, dialysis patients often develop an iron deficiency anemia like in chronic renal failure. Is it clear? That can lead, so, and also chronic renal failure can also lead to a folic acid deficiency, and dialysis therapy, that's why it can result now to a hyperchromic anemia. So in dialysis patient, don't forget that in renal failure you also have malnutrition as one of the complications. So in malnutrition, you're going to have also what, a folic acid deficiency that is going to result now instead into a hyperchromic anemia. So that's why you have other cases where in renal anemia you can have a hypochromic and hyperchromic, but the major one is normochromic anemia. Now the next is a bone marrow aplasia, anemia from bone marrow aplasia. So you can have a pure red cell aplasia, that is erythroblastopenia. So in the bone marrow you are going to have erythroblastopenia. So erythroblastopenia is a sense of purely aplastic condition in red cell series, and is extremely rare. Is it clear? So we have what is called the diamond black fan anemia, which is a congenital hypoplastic anemia. In this case, with diamond black fan anemia, you are born with an erythroblastopenia. Your erythroblasts do not produce the red blood cells. Is it clear? That's called diamond black fan anemia. Is a congenital form of this disease. So when you have an acquired acute transient, you can have acquired acute transient infection in adult and children, usually caused by viruses such as parvovirus B19, may cause also a red cell aplasia. Is it clear? So when you have an acquired infection with a parvovirus B19, it's also going to cause you a red cell aplasia. Now you can have also, this is an acute case. Now in case of a chronic acquired erythroblastosis, is frequently due to a thymoma or a autoimmune etiology. So those are the three main cases. It can be congenital, it can be acquired. Congenital is diamond black fan aplasia. Is it clear? So diamond black fan anemia, which is a congenital aplasia. It can be acquired. If it's acquired, it can be acute or chronic. In case of acute acquired, it's in the case of parvovirus B19 infection. In case of chronic acquired, it's in the case of an autoimmune disease or a case of a thymoma. Is it clear? So anemia in pure erythroblastosis is normochromic anemia. So you have no problem with the storage of red blood cells or of the iron. So iron in the blood is normal without significant changes in the complete blood count for the white blood cells. So white blood cell is going to be normal, but when you have an erythroblastosis, so it means that there's only the erythroblast that is going to affect it. The white blood cell count and the thrombocyte count is usually normal. In all this anemia, the bone marrow show well-developed granulocytopenia and megakaryocytopenia, but erythropoiesis is the one which is affected. So now let's visualize now the diagram. So these are the forms of bone marrow in case of aplasias. So we have bone marrow cytology in erythroblastopenia. In erythroblastopenia, only activated cells are granulopoiesis system and the megakaryocytopoiesis system. Is it clear? Megakaryopoiesis. So here to visualize that one in this diagram A, you visualize that the bone marrow cytology, there is little erythroblast, and there is going to be more of the myeloblast, and you have more of the megakaryocytes. Is it clear? So the erythroblast level is low in the diagram. In diagram B, you have a bone marrow aplasia with, so you have a bone marrow aplasia here. Hematopoiesis completely absent. So here completely there is bone marrow aplasia, hematopoiesis completely absent. Here at least you have some megakaryocytes, you have some granulocytes. So is it clear? But here you have no, you see actually there is fibrosis here. So you have fibrosis of tissue, there is no cell. It means that here is a bone marrow aplasia which involves the complete cell series. Now the diagram C, we can see giant erythroblast with the arrow diagram here. So this is giant erythroblast in the bone marrow. So this is in a case with an acute parvo B19 infection. You can see giant erythroblast here. Is it clear? So now in diagram D, you have conspicuous binuclear erythroblast in the bone marrow in patients with congenital dyserythropoietic anemia. Is it clear? So this is a congenital dyserythropoietic anemia. You're going to have a binuclear. So binuclear erythroblast. So this is in a case like in the case of a diamond black fan anemia, which is congenital. Now the next disease that you're going to see is aplasia of all bone marrow series. So when you have aplasia, here is all the bone marrow series is affected. So it can be a pan myelopathy or it can also be called a pan-myelophysis, or it can be called aplastic anemia. So when I say aplastic anemia, it means that I'm involving all the bone marrow. When I'm saying myelophysis anemia, I just mean infiltration and involve all the bone marrow. And when I say pan-myelopathy, it's all the bone marrow that is still affected. So this is a reduction in the erythrocyte, the granulocyte, and the thrombocyte cell count in this series, which may progress to even a number of 0. Pathologically, this life-threatening disease is result to damage to hematopoietic stem cell, often chemical toxin, or occasionally oral infection, or occasionally viral infection. So the term pan-myeloid is synonymous to aplastic anemia. So those are the terms that you can still use. In complete blood count, you see no cells. Now, what are the differential diagnosis versus reduction in cell count of several? So after thorough analysis, most cytopenia with hyperplasia of the bone marrow have been defined as myelodysplasia. If you have low level of the blood cells, is it clear, and you have a hyperplasia inside the bone marrow. If you have low level of the blood cells, that is a pancytopenia, and you have hyperplasia of the bone marrow, then you have to think of a myelodysplasia. Is it clear? So the term myelodysplasia is going to be used. But Myelodysplastic syndrome, as I've already said, myelodysplastic syndrome is going to be in case where you have an increased number in the cell series. So if you have an increased number in the red blood cells, increased number in the white blood cells, increased number in the platelet, that is going to be called a myelodysplastic syndrome. And an example of myelodysplastic syndrome is a Vasquez disease, where you have an increased number of the red blood cells with the Polycythemia vera. Is it clear? But now, myelodysplasia is when you have a decreased number of the cell series. You can have decreased number of red blood cells, white blood cells, or platelets, but you have a hyperplasia of the bone marrow. That is the term used for myelodysplasia. Is it clear? Now, the next one is cytopenia of the bone marrow. Fibrosis point is called a myeloproliferative type disease. So if you have a cytopenia of the bone marrow, so when you have a cytopenia, that is low level of the blood series, and now inside the bone marrow there is also a cytopenia, is it clear? Then it's called a myeloproliferative type disease. Is it clear? So you have a term myeloproliferative type disease. Now if you have cytopenia, can of course that also affect the bone marrow. Infiltration by malignant cells. So in this case, when you say infiltration of malignant cells, it means that what you see other cells, now cell type inside the bone marrow. You don't see erythroblast, don't see myeloblast, don't see myelochloroblast, but you see other cell types like the prostate cell type, prostate cancer cell type. You see the thyroid cancer cell type, you see the ovarian cancer cell type. All these, like carcinomas and sarcomas inside the bone marrow, you think of infiltration. And another term meaning for infiltration is called feces. So in this case, it's going to be called myelostasis disease. Is it clear? So when you have fibrosis, myeloproliferative, you have infiltration, myelopsysis, and you have hyperplasia, is going to be myelodysplasia. Now the next one, if you have cytopenia, can result from a vitamin B12 or folic acid deficiency. Is it clear? It's going to result to a hyperchromic myelodysplastic hyperchromic anemia. Now the next one is another cause of cytopenia is expansion of malignant hematopoietic cells. So you can have your own hematopoietic cell being increasing in number. That is expansion. Is it clear? This is easily overloaded in malignant cells in the bloodstream. So it's called, you can have in the case of a lymphadenoma, you can have in the case of a leukemia, that is an aleukemic leukemia without peripheral blast cells, and you can have also a plasmacytoma. So all these are cases where you can have expansion of the own bone marrow. It can either be the plasma cell that is being expanded, like in a plasmacytoma. You can have a case where it is it can be lymphadenoma. Is it clear? So from the lymph nodes, you have adenomatic cells that are being produced, and you can also have an allochemic leukemia, where you don't have blood cells in the blood, but there are leukemic cells inside the bone marrow. Another case of cytopenia also develop from the cause of high dose radiations. So this is another case where you can have a cytopenia from high dose radiations, that is from therapies or chemotherapies. In such cases where you can reduce the blood cell count, where both the blood cell count and that in the bone marrow. Is it clear? So another case of cytopenia can be caused by a panmyelopathy. So mechanism. So these are the different mechanisms via which you can have a cytopenia, and the cytopenia can exist in a unicytopenia form where only one cell is affected, a bicytopenia form, or a tricytopenia form. Bicytopenia when two cell series are affected, and tricytopenia when three cell series are affected. Now, you have substances suspected or proven to cause myelopathy. So, and these are all the mechanisms via which panmyelopathy can occur. Now, the substances that have been proven, we have drugs. Also, drugs is another one. We have analgesics, anti-rheumatic drugs can be involved. So these are example of these drugs. You have antibiotics. This is an example of antibiotic, chloramphenicol, sulforamide. We have anticonvulsives, hydrangestrone. So all these are drugs which are involved here. We have also sedative drug, phenothiazine. We have insecticides. We have solvent. We have viruses. So all these can cause a panmyelopathy, a pancytopenia. So now these are the different cases involved there. Now the next one is a bone marrow carcinosis. So if you have unexplained anemia, at a nota bene is that one, unexplained anemia, thrombocytopenia, leukocytopenia, any possible trigger must be discontinued or avoided. Myeloptosis or aplastic is an acute disease that can only be overcome by aggressive treatment like glucocorticoid, cyclosporine, and anti-myelocyte, provided that they are caused by an autoimmune disorder in order to cause an immune suppression. Now the next one is bone marrow carcinosis and other space occupying processes. So in bone marrow carcinosis, there is infiltration of the bone marrow. So anemia that results from bone marrow infiltration by growing and space occupying tumors, metastasis in the principle of normochromic. So here the anemia, since they are metastasizing here, they are not going to be involving with a change in the number of the iron, the iron storage, and they are not going to be involved with a problem with the vitamin B9 and vitamin B12 deficiency. Is it clear? Because you need to know that one, if you have low iron, you're going to have hypochromic anemia, and if you have low vitamin B12 and B9, you're going to have a hyperchromic anemia with megaloblastic. Is it clear? But usually the myelodysplastic anemia, which is infiltration of the bone marrow, do not affect the storage of the iron or vitamin B12 and B9. Is it clear? Since it does not affect both of them, you are going to have also a normochromic anemia, because it inhibits the production of the red blood cells. Is it clear? So you are going to have a normochromic anemia, just like in cases of a renal anemia. So normoblast in the is a differential blood analysis. You're going to see normoblast there, particularly suggest the possibility of bone marrow carcinosis, because their presence imply the destruction of the bone marrow blood barrier. So you are going to see normoblast like erythroblast, myeloblast, and all those blastic cells now inside the bone. Is it clear? So inside the blood, because there is a destruction at the level of the blood bone marrow barrier by those carcinomatous cells. So you are going to see the blood cells inside blood. So bone metastasis for malignant tumors rarely affect the bone marrow and hematopoiesis, and if they do occur, it is usually late. The most common metastasis in the bone marrow derive from small cell bronchocarcinoma and the breast cancer. Those are the two most common metastasis with the bone marrow. One is small cell bronchocarcinoma, the lung cancer, and two is breast cancer. And if the other ones occur, is because they occur at a late period. So those are the different cases that you can have. Now in differential diagnosis, the effect of direct bone marrow infiltration must be distinguished from the phenomena caused by microangiopathic hemolytic anemia. Is it clear? You should distinguish always the normochromic anemia from a myelodysplastic anemia, from that of microangiopathic anemia, where you are going to have poikilocytosis and isococytosis, and you can have also a normochromic normocytic anemia. Is it clear? So that is, you have to distinguish both of them in order for you to see. Now we have now the cytology in cases of a myelodysplastic anemia. So this is the cytology. So you have bone marrow carcinosis. Diagram A and B is going to show you the bone marrow smear at a low magnification, showing island of infiltration with hematogenous cell type. Is it clear? So so we have an alternative apparently different cell types which do. So here actually you don't see the same cell types like we do see like myeloblast, erythroblast and megakaryoblast. Here you don't see distinguish easily those type of cells. See, the cells have changed in morphology. There is no more the same cell type we do to know. Is it clear? So all display identical chromatin structure. All cells here displays identical chromatin structure, and the cytoplasm of the bone marrow carcinosis in the breast cancer. So that is the same cytoplasm like in breast cancer. The next one is diagram B, where you have in diagram C, sorry, where you have island of you have this one is for breast cancer and this one is for small cell carcinoma from the bronchial tree. Now this diagram in diagram C is island of dedifferentiated cells in the bone marrow, cannot be assigned to any hematopoietic image, as you can visualize here. So this is not a typical image. You can see now in this case you're going to visualize now is the metastatic cancer cells inside the bone marrow. Now the next one now is a hyperchromic anemia. Now I've forgotten to say that the best way to distinguish which cell type is going to be found is a immunocytochemistry, where you're going to use antibodies in order for you to distinguish which cell types are located at the level of the bone marrow, because you cannot easily distinguish them. You can now use immunocytochemistry such that you use antibodies that are going to react with these cells, that these cells are going to react to this because they have certain receptors which are specific to them, and then when they react to this you can now visualize it on microscopy. Now the next type of anemia, you're going to have hyperchromic anemia. Is it clear? So hyperchromic anemia, in this case you're going to have an MCH which is greater than 32 grams per deciliter. That is the mean corpuscular hemoglobin level. It's going to be greater than, it's going to be greater than 32. Is it clear? So those are picograms. So now we have now the most common causes of hyperchromic anemia. What are the causes? The first one is nutritional deficiency, when you have lack milk, vegetable diet, alcoholism. So you are going to have nutritional deficiency in vitamin B12 or folic acid. So these are the two main type of causes of hyperchromic anemia, when you have vitamin B12 deficiency and you have folic acid deficiency. So which are the cases that is going to cause vitamin B12 deficiency? You have nutritional deficiency, deficit of vitamin B12, when you don't eat goat milk, low level of goat milk, when you have low level of vegetable diet, low level of goat milk, low level of vegetable diet, low level is going to result, and alcoholism is going to result in low vitamin B12. That's why an alcoholic patient is usually going to have instead a hyperchromic anemia. He may not have an anemia, but his level of MCH is going to be very high because he has vitamin B12 deficiency. Now in case of impaired absorption of vitamin B12, like in the case of a genuine pernicious anemia, is it clear? You have a case of genuine pernicious anemia where you don't absorb vitamin B12 at the level of the terminal ileum. We have a status after gastrectomy. In case where you have gastrectomy, normally the stomach produces what is called the intrinsic factor, and the intrinsic factor is used at the level of the terminal ileum for the absorption of vitamin B12. Is it clear? So when you have gastrectomy, you don't produce intrinsic factor again. So there is no intrinsic factor for the reabsorption of vitamin B12 at the level of the terminal ileum. So we are going to have vitamin B12 deficiency. The next one is ileal resection. Ileal resection, if I cut now your ileum, there is no terminal ileum again for the reabsorption of vitamin B12. Crohn's disease, if the Crohn's disease affect that part of the terminal ileum, you are also going to have no part of the ileum for you to reabsorb the vitamin B12. We have celiac disease, the same thing, sprue, that is cirrhosis. We have intestinal diverticulosis, the same mechanism. Insufficiency of the exocrine pancreas, because the exocrine pancreas also produces factors like intrinsic factor and other forms of enzymes which can be involved with the reabsorption of vitamin B12. And we have fish tapeworm, which reabsorbs vitamin B12 and leaves you no vitamin B12 for your reabsorption. Now the fish tapeworm is called Diphyllobotium latum and occurs in patients that eat fish who are infected by that tapeworm. Now, folic acid deficiency. In case of folic acid deficiency, we have chronic abuse of alcohol, just like alcoholism here, but in nutritional deficit. That's the only case with nutritional deficit you can have folic acid deficiency. Because folic acid is present in most of all food, so it's only when you're alcoholic that you can have that deficiency. The next one is impaired reabsorption, like in case of tropical sprue, like cirrhosis. You have increased requirement like pregnancy, like in case of hemolytic anemia. Let's say in case where you have hemolytic anemia, at the beginning you're going to have hemolysis. When you have hemolysis, you need to know that what iron is more present in food and it is more stored in the body compared to vitamin B9. Is it clear? So it means that what if there is hemolysis inside the body, it means that when there is hemolysis inside the body, their body stores first iron. So immediately there is hemolysis, your body is going to release the iron such that your red blood cell is going to use the iron for its production. And also iron is easily found inside is more found in the diet than vitamin B9. So just imagine that you first have hemolysis. When you have hemolysis, the person that is going to be more deficient is going to be vitamin B12 than vitamin B9. Why? Because when there is hemolysis, there is no storage of vitamin. There is usually no storage of vitamin B9 inside the human body. Is it clear? So when there is hemolysis, there is going to be deficiency of vitamin B9. So immediately after hemolysis, you are going to have a hyperchromic anemia. It will begin with a normochromic anemia, and at the end, you're going to have a hyperchromic anemia because you have a B9 deficiency. The next one, you have also pregnancy, where you have vitamin B9, which is used by the fetus. Now you have interference / antagonism. So with certain chemicals, like antagonisms, like in case of phenyl you have cytostatic anti-metabolic drugs, you have dimethoprim, you have oral contraceptive and alcohol. So all these can act as antagonists. So this is the cytology now of a hyperchromic anemia. So in hyperchromic anemia, you're going to see that the cell is going to be very, very, very dark. So here you have marked anisococytosis. When you have marked anisococytosis like that, it is a hyperchromic anemia with another etiology around. So you have anisococytosis in addition to the normalized erythrocyte. So you have macrocyte also, as you can see in diagram 2. Diagram 2, you see the macrocyte. So diagram 1, you have a normal cell side erythrocyte and large, and this one, diagram 3, is a large ovoid megalocyte, which can be seen here. So this is seen in megaloblastic anemia. Megaloblastic anemia, that's why you have anisococytosis. Some are cells, some are large, some are normal size, some are large size, and like all macrocytes, and the others are megalocytes. Is it clear? So this one is the normal size, this one is large size, and this one is mega large size. That's why this one is called normocyte. This one is called a macrocyte, and this one is called a megalocyte. So these are the different cell type, and that's why it's going to result now to an anisococytosis. Anisococytosis is different sizes, which is seen in megaloblastic anemia, basically. So which cell types are seen in megaloblastic anemia? We have macrocytes and megalocytes, basically. Now the diagram B. So in diagram B, you're going to see hyperchromic. So we also have hyperchromic anemia here, and this hyperchromic anemia, you see red cells precursor at this level. You see red cell precursor may be released in the peripheral blood. Here we have polychromatic erythroblast. You can also visualize polychromatic erythroblast at this level. So in diagram C, you can now in diagram C and D, it's the level of the bone marrow where you see megaloblastic anemia, a bone marrow megaloblastic anemia. Diagram 1 is going to be slight, and diagram 2 you have marked you have loosening up of the nuclear structure in the binuclear nuclearity, basically. Now diagram 3 is going to show giant forms of diagram 3 shows giant forms of nuclear structures, and then giant forms of band granulocytes, and diagram 4 are often present. So now these are the different cases where you can visualize this megaloblastic anemia. So after this, now this next diagram now is going to show you a myelodysplastic syndrome, basically. So this is going to show you now a myelodysplastic syndrome. So with this as differential in hyperchromic anemia, you can have myelodysplastic syndrome. With myelodysplastic syndrome, as I've told you before, you're going to have an increased number of the cell series. You have myelodysplastic syndrome. So it's another cause where you can have a hyperchromic anemia. So diagram A, you have strongly basophilic stripling in the cytoplasm, as you can visualize here, basically. Diagram B, you're going to see a myeloblast in hyperchromic erythrocyte as an example. Diagram C, you're going to see in the case here, you have used now a Prussian blue in order to visualize the reticulocyte. You see that there's going to be a high level of reticulocyte in myelodysplastic syndrome, as you can visualize it. And diagram D is going to show you the bone marrow. In bone marrow with myelodysplasia, you can see clinical hyperchromic cells, and you have hyperplasia of the cells in the bone marrow. So all that is going to show you a myelodysplastic syndrome. So we say here that what megaloblastic anemia is the cell density in the bone marrow is always remarkably high, as you have seen. Large to medium-sized blast cells and round nuclei are going to be visualized. Also, the granulocyte series anomaly become obvious as the myelocyte stage and characterized by giant cells that are loosely structured nuclei develop, which tend to classify them as myelocytes or stap cells, basically. So that is what you visualize now in this type of anemia. Now the next thing to see here are going to be erythrocyte inclusion. Erythrocyte normally shows some fairly homogeneous hemoglobinization after panoptic staining, basically. So there are certain inclusion inside erythrocyte that I'm going to show you in this image. So these are erythrocyte inclusions. So we have polychromatic erythrocyte with lines. So with line dense basophilic on cell stripling. So that is diagram A. You can see basophilic stripping here. We have polychromatic erythrocyte with basophilic stripping. That's the first inclusion. Second, diagram B, you can see erythrocyte with Howell-Joly bodies. These are Howell-Joly bodies here. So it's another erythrocyte inclusions, in addition to lymphocyte after splenectomy. So all this, you can see Howell-Joly bodies, you can see lymphocyte, and this is going to show you that they say splenectomy that has occurred. Diagram C, you can visualize also two Howell-Joly bodies. So Howell-Joly bodies, you see that it is close to the central pallor of the red blood cells. So normally the spleen is the one that is removing those one hour red blood cells, but these one hour red blood cells are normally removed by the spleen because this is splenectomy. So that's why you can visualize those orange red bodies. So these are two orange red bodies alongside with orthochromatic. This one is orthochromatic erythroblast with basophilic. So this is seen now in thalassemia. Is it clear? So you can visualize this and this. So when you see an orthochromatic, you need to know that what here there is orthochromatic. Why? Because hemoglobin is not easily found at the level of thalassemia. You need to know that thalassemia is an abnormality with the hemoglobin production. So the cells want to stay in a basophilic stage. That's why you can, and it's orthochromatic phase. So that's why the cell type is going to be orthochromatic erythroblast with some basophilic stripping inside. That shows thalassemia. Now the next diagram is diagram D, where we have erythrocyte with delicate cardboard rings. As you can see here, you can see cardboard rings. Erythrocyte with delicate cardboard rings shown with the arrow here. So there is a case of osteomyelosclerosis that we're going to see later. So here there is a case of osteomyelosclerosis when you see the cardboard rings. Now in diagram E, you see thrombocyte layered into onto the erythrocyte. So here you have a thrombocyte and erythrocyte are together. So that's another inclusion that I'm going to call. Diagram F now and G, you have fixation and staining artifacts. So when you have a problem with fixation and staining, so all these are the erythrocyte inclusions. Now, what is the hematologic diagnosis of malaria? Now, these are the different forms of malaria. Now, we need to know that what we have 4 types of malaria species. We have falciparum, Plasmodium falciparum, vivax, ovale, and malaria. Now, we also have another called we have even a feed one which has been recently found from the chimpanzee. Is it clear? Now, these are the different falciparum, Plasmodium falciparum. So the Plasmodium falciparum, this is the young and the young trophozoite form. This is the intermediate trophozoite form. This is the Shizuon form, the mature Shizuon form. This is the mature macromegalocyte, and this last one is the micromegalocyte. Is it clear? So all this is going to show you the diagram now of the different species. So we start with the Plasmodium falciparum. So Plasmodium, you see, this is how the young cell is going to resemble. Is it clear? But because you need to know that what in the cell cycle, in the cycle of Plasmodium, it starts by injecting the trophozoite in the blood. It starts by injecting the sporozoite in the blood. So when the mosquito inject the sporozoite, an infected mosquito injects sporozoite of any Plasmodium species type inside the blood of a human, that sporozoite is going to move to the liver, and the sporozoites now are going to produce the trophozoite at the level when they infect the liver. So when you infect the liver, they produce now the trophozoites, and the trophozoites now are released in the blood. Is it clear? Or you can also produce the hypnozoite, and the hypnozoites are the dormant state, which can produce only by the vivax and the ovale. That's why in those cases you can have a relapsing malaria. Is it clear? So those in the case. So the trophozoites, which are going to enter in the blood and cause the erythrocytic cycle, where they are going to infect the blood, and they are going to produce first the immature trophozoite, then the mature trophozoite, and then later on they are going to produce now the Shizuons, and then the Shizuons now are going to be converted into a macromegaloblast, and then you have micromegaloblast. That's in the case where you have a rupture now of the red blood cells. Is it clear? And now the rupture of the red blood cells is going to release now other trophozoites that are going to infect again other red blood cells. Is it clear? So those are the cases that involve here. So this is how a falciparum young trophozoite inside red blood cell is involved. You usually have multiple trophozoite inside the red blood cell. Here you only have a single trophozoite inside the red blood cell. Here you also have a single red blood cell, single trophozoite inside red blood cell with other inclusions here. And then here you have a single. So this is vivax ovale malaria. Now the next diagram here is in the case of intermediate stage of trophozoites or mature stage of trophozoites. So here you visualize that there are trophozoites seen as such. So the diagram is seen as such. Here this is how the trophozoites are going to be spaced out. Here in ovale is going to be spaced out like that, and malaria is going to be spaced out like that. Now the Shizuon form. The Shizuon form, you see that what? Here you have a big cell which is Shizuons. Here you have also a Shizuons, and then you see trophozoite inside. Here you also have a Shizuon, you see trophozoite inside, and this is similarly. This is the macromega myeloblasts. So this is a macrogametocyte. Sorry, so I made an error. So you need to know that after the Shizuon form, you have what is called the gametocyte, because the trophozoites, there are certain Shizuons that may convert to produce the gametocyte, and those gametocytes are divided into two. You can have male and you have female gametocyte, respectively, based on their macro and micro sizes. Is it clear? So we have female and male gametocytes, and the female and male gametocytes are the ones that are going to be infect now a new Anopheles mosquito. So when a non-infected Anopheles mosquito now bites an infected man, they are going to suck up his blood with the female and the male gametocyte, which can be micro or macro gametocyte. Is it clear? So now when they suck it up like that, you have now the fusion of the male and the female gametocyte at the level of the stomach of the mosquito. When you have the fusion now, it's going to produce now an oocyte, and that oocyte is going to release now sporozoites now, and that sporozoid is going to move through the blood of this mosquito and then enter into his saliva for the infection of other human beings. So this is the macrogametocyte of this one of the falciparum. Is a case of this in the case of ovale. This in the case of this is the case of vivax ovale, and this is the case of malaria. And this is the microgametocytes of each one here. So now these are the specific characteristics now of each of them. Now you need to know that what the falciparum species. So this is the disease is called falciparum malaria. So is it clear? So falciparum malaria is caused by Plasmodium falciparum. Now we have the exoerythrocytic phase. So the exoerythrocytic phase, it means that what? It means that it is out of the erythrocyte. And that exoerythrocytic phase is 7 to 15 days. Does not form liver hypnozoites. In this case, you don't have liver hypnozoites. Why? So since you don't have liver hypnozoites, falciparum does not cause relapsing anemia. Is it clear? It is only malaria, it's only ovale and vivax that cause relapsing malaria, because they have hypnozoites. Now when you have 7 to 15 days being the exoerythrocytic cycle, you need to know that usually malaria causes symptoms because of anemia and fever. So those are the two major, so that is the two major clinical pathology of malaria, this anemia and fever. So it means that the exoerythrocytic cycle phase also corresponds to the incubation period of the Plasmodium falciparum. So it is 7 to 15 days, the incubation period. Is it clear? And it does not have the liver hypnosis. And you also need to know that what? You need to know that Plasmodium falciparum is the most virulent, and is what is found in our context. So the major cause of malaria in our context is Plasmodium falciparum. Now the erythrocytic phase now stays for 48 hours. So it means that what? It is very acute. So only 48 hours you have many symptoms of plasmodium falciparum symptoms, requiring fever is recurring fever is rare, as I've told you, because there is no hematocyte to release again other trophocytes in the blood. So immediately you finish it, anemia here is completely falciparum, you have no anemia again. So the next one is clinical characteristics. You have potentially lethal disease, so that's why it's most virulent. You have widely therapy resistant, and there is usually no recurrence after recovery. That's what is good with it. After recovery, there is no recurrence, basically, because there is no hematocyte, but it is potentially lethal and there is resistance to the therapy. That's why malaria has killed many people, unfortunately, in our context. That's in account Chicago. Then the next one now is tertian malaria. So tertian malaria can be caused by Plasmodium vivax and Plasmodium ovale. The exoerythrocytic cycle or the incubation period is 12 to 18 days. So this one forms liver hematocyte, and the erythrocytic phase is 48 days, 48 hours. So now for the first one, which is vivax, it is a benign form, and we have recurrence up to 2 years after infection. So after infection, there is still hematocyte inside your liver. You can have recurrence 2 years after. So in this patient, you have malaria every after 2 years, need to be treated for vivax. Now Plasmodium ovale, we have benign form also. Plasmodium ovale is you have benign form also. We have recurrence up to 5 years after infection. So 5 years after infection, you have a recurrence of every 5 years after infection. Now the next one is quartan fever, quartan malaria. So quartan malaria is caused by Plasmodium malariae. So the incubation period is the longest one, that's 18 to 40 days, and does not form liver hematocytes. The erythrocytic phase also the longest one, that's 72 hours, and it's a benign form of recurrence, possibly up to 30 years after infection. Is it clear? Now the question that you ask me is, why is it that this quartan malaria, which is Plasmodium malaria, is recurring but it does not produce liver hematocytes? The simple answer is that it does not produce liver hematocytes, but it's recurring because these cells are staying inside the red blood cells. So there are certain Shizuon cells so when they are coming out from the red blood cells, they don't break out the red blood cells. So certain cells stay inside the red blood cells, and it is only when the red blood cells are being broken down by the spleen after their life cycle of 3 months that it is recurring. So the recurrence of this, it is from 3 months to 30 years. So it's going to affect all your red blood cells. When the spleen is breaking one red blood cells, the Shizuon that was present there is going to move out and affect other red blood cells for up to 30 years. So the recurrence is 3 months to 30 years. Is it clear? So this form of anemia, which is by tertian malaria, is called relapsing fever. Why? Because a relapsing fever is a case where it's a malaria where you have infection which is being treated and then which reoccur. Now this one, which is quartan malaria caused by Plasmodium malaria, is called instead a recrudescent malaria. Is it clear? So in this case, in recrudescent malaria, you have infection and then you are well after the infection. You are not treated, you are well, and then you are having the fever and the infection. That is a recrudescent malaria caused by Plasmodium malariae. Now this is now the blood analysis of malaria. So that's the blood analysis of malaria. You have trophozoites, Plasmodium falciparum, that you can visualize here. So trophozoites of Plasmodium falciparum that you can visualize in diagram A. You have or malignant tertian malaria infection. Now the next one, so we see diagram 1. That's one simple. You have a simple signet ring form. You have a double signet ring form in diagram 2 here. You have erythrocyte basophilic. So you have erythrocyte basophilic without Plasmodium in diagram 3. So without Plasmodium, you can visualize here in diagram 3. Yeah, basophilic erythrocyte in diagram 3. Now the next one, you have diagram B and C. are showing Plasmodium falciparum single invasion with delicate trophozoite. So in diagram 1 is that, and diagram 2 we have multiple invasion of Plasmodium falciparum. Now diagram E and D and E are going to show now the gametocytes, exactly stages of the Plasmodium falciparum. So here is one gametocyte here, and here is another gametocyte. One is going to reside out of the red blood cells, and one is going to reside inside the red blood cell. So those are the next one. Now the next disease under erythrocytic disease is going to be Polycythemia vera, which is called erythemic polycythemia and erythrocytosis. So this is an increased number of erythrocyte, hemoglobin and hematocrit above the normal range due to causes unrelated to hematopoiesis. Is it clear? So in Polycythemia vera, it's an increased number of the red blood cells, but the causes is unrelated to hematopoiesis. That is why Polycythemia vera is not Vasquez disease in the case of Myelodysplastic Syndrome. So the majority of cases are now referred as secondary erythrocytosis or secondary polycythemia. So when you have a Polycythemia vera, it is usually because of the causes which are unrelated to hematopoiesis, and these causes are usually secondary polycythemia. So what are the causes of secondary erythrocytosis, which is not due to an increased level, this is not due to the hematopoiesis? You can have reduced oxygen transport capacity, like in the case of carboxyhemoglobin level, in case of formation of chronic smokers, case of high altitude hypoxia, chronic obstructive pulmonary disease, heart defects, all that may going to result to low level of oxygen and cause polycythemia. Second, you have reduced oxygen released by hemoglobin, or in case of renal hypoxia. So you have congenital phosphoglycerate deficiency, you have hydronephrosis, you have renal cyst, you have renal artery stenosis. So all this is going to result to renal hypoxia. When you have renal hypoxia, you are going to have excess level of erythropoietin in blood. So renal hypoxia may come because of a renal cyst, which may result to an anemia, which may result to a polycythemia vera. You can have also a polycythemia due to a hydronephrosis, because it's going to cause also a renal hypoxia. You can have also that is going to be due to a renal artery stenosis, is also going to result to a polycythemia. Now we have autonomous erythropoietin biosynthesis, like in a renal carcinoma. So when you have excess erythropoietin just produced like that, like in the case of renal carcinoma or in the case of adenoma. Is it clear? So now these are the revised criteria for diagnosis of Polycythemia vera. If you have elevated erythrocyte level, is 1. The second is absence of any trigger of secondary polycythemia. If there is any trigger of secondary polycythemia, that is not going to be Polycythemia vera. So Polycythemia vera is not secondary polycythemia. You must exclude the causes of secondary erythrocytosis. Is it clear? So you must exclude all this, like all this that you have seen. So there must be absence of any trigger of a polycythemia. There must be a palpable splenomegaly. In the case of polycythemia, you must also see a palpable splenomegaly. There must be a clonalytic test that must be present. There must be thrombocytosis also in Polycythemia vera. There must be leukocytosis of greater than 10 times 10 raised to the power 9 per liter. There must be splenomegaly, as I've already said, and there must also be endogenous erythrocytic catalog. So in order for you, so this is based on now the revised criteria according to Pearson and Messinesi. So when it's according to Pearson and Messinesi, so this is the criteria for Polycythemia vera. So the criteria is A1, A2, A3, A4, B1, B2, B3, B4. Now, in order for you to make a diagnosis, it is A1 plus A2 plus A3 or A4 or A1 plus A2 plus A2 again times B. Is it clear? Plus all the so 2B. If you have 2B, it means that you have all that. Is it clear? So those are the different cases. So that's the diagnostic criteria of polycythemia vera. Now polycythemia vera and secondary erythrocytosis, so those are the different. Now usually polycythemia vera is associated with the bone marrow, while a secondary erythrocytosis is due to other causes. Now in reactive secondary erythrocytosis, there is usually only an increase in erythropoiesis. Is it clear? So when it is reactive, there is only erythropoiesis that is affected. Now while in polycythemia, when you have a polycythemia vera, you can have megalopoiesis and often granulopoiesis that may also be associated. So you can visualize here in diagram A, you have only an increase in case of secondary polycythemia, only the erythropoiesis is going to be activated. You see only the erythrocyte precursors are activated. But here in case of a polycythemia vera, you have many cell types. You have a thrombocytopoiesis, like here you can have also a granulocytopoiesis, like the different cells here. Is it clear? Now in diagram D, now you can visualize here bone marrow smear at low magnification in polycythemia vera show an increased cell density and proliferation of megakaryoblast cells. Is it clear? Megakaryocyte. And in diagram E, polycythemia vera iron staining showing no iron storage particles. Is it clear? So those are the different cases of polycythemia vera. So from this case, we are finished with all the disease of the erythrocytes level, and then we continue now with the disease of the thrombocyte abnormalities. So we say thanks for your kind attention. Please don't forget to like and subscribe for our channel, Science Video Makers. Thank you.